Hi all, thank you so much for being here. Very excited for today's webinar. I'm joined by two exceptional speakers. They are Tim Lawless, the Senior Vice President and Global Health Lead at Publicis Sapient, and Ashma Gupta, the Global Director of Healthcare Strategy and Solutions at Google Cloud. Thank you both very much for being here. In terms of today's webinar, as you all know, we will be looking at the art of the possible, redefining healthcare with agentic AI. To set the tone for the structure of the conversation, the way that we're going to run it today is we'll do some very brief introductions now, then a set of rapid fire questions just to set the tone and the scene, I suppose. Then we'll move on to the panel discussion, which I'm very excited for. At the end, there will be Q&A. As Nikita mentioned at the very beginning there, please do submit your questions for the Q&A throughout the webinar. And at the end, we'll have some closing remarks. I'm very excited to be joined by you both, Tim and Ashma. Shall we get on with the rapid fire?
Sure.
Yeah, let's do it.
Fabulous. Okay. So rapid fire questions. There's a lot of misconceptions that teams still have when they start exploring agentic AI. From your experiences at both of your organizations, what are the biggest misconceptions that teams still have with agentic AI?
I guess I'll go first.
Go for it.
Yeah, so I mean, I think there's a few, but I'll just name one specific one, which is that when you're trying to build agentic AI for scale, there's actually a lot of engineering behind it. And so it's not just simply like a lot of people are used to ChatGPT and kind of writing some prompts and things of that nature. But to write something that's robust and reliable, there's a lot of guardrails and things you need to put in place, and a lot of thinking you got to put around that.
Very interesting.
Yeah, I would add to that. As Tim said, the second one that I see from the business perspective is as people are designing agentic AI, there's a belief that agents are meant to operate independently of clinicians, but it is on behalf of clinicians. We can stress upon that more, that agentic AI is about extending clinical capacity. It's not independent agents going and taking rogue actions. And of course, that means robust governance and data foundations. But agentic AI is assistive technology for clinicians, for nurses, for healthcare. I think we need to kind of double down on that point.
That's a beautiful way of phrasing it, on behalf of. It's a very nice way of putting it. Okay, well, let's move on to the next one. So what foundations should every organization put in place before experimenting with agentic AI? We'll start with Ashma for that one.
Yeah, so I would say start with data maturity. High quality, clean data is the must. It is the prerequisite. And second is appropriately permission data for the agents to act upon. So have the data, make sure it's clean. Second, permissible data for agent to action upon. And third, which is very important, is governance. Defining clear policies on what agent can and cannot do, workflow clarity. How many people have actually mapped their workflows end to end and say where agentic actions can be introduced, and operation readiness. And I would end it with this. Agentic AI is actually 20% model. 80% of it is that infrastructure, process, governance, people, and people have it kind of flipped. There's so much obsession about the model, of course. We obsess on Gemini model as well, but model alone is not sufficient for agentic AI. You need to think across the value chain.
Very interesting. And Tim, how about you? What are your thoughts around the foundations organizations should put in place?
Well, I agree with all those, and Ashim was right. Like, yeah, the agent is kind of the sexy part. People are excited about that. You got to do all the other stuff to really make it work. And I would add to everything she said is exactly on point. I would also add though that this is in general technology, but AI, like the biggest thing that keeps you from realizing things is people. So you need to I think you need to train people. She talked about like standards and things of that nature, thinking about bias, ethics, also what AI can be for people. I think you need to train, educate, and get people involved so that they don't feel threatened by AI. They feel part of the effort.
It's going to be a big push for a lot of organizations across all industries for the next few years, that education piece. Maybe we'll drill down on that a little later on. What's the one thing that leaders should stop doing with AI and one thing they should start doing instead. Tim, would you mind taking that one?
Sure. Well, I had a little controversial one, which is like stop doing POCs. I don't actually
And the
mean
same, by the way.
you actually do need to do POCs, but there's too many POCs and not enough like commitment to taking it to the next level to production. Because I think people eventually are going to be like, we're just spending all this money on POCs and nothing's happening. So I think we need more commitment to take it all the way.
Certainly
I
slightly
would,
controversial.
go ahead.
How about you?
I was just going to build on Tim's point. The other one I would say is stop thinking AI is the futuristic thing and is going to happen. It's here and now. And for us, we need to embrace it, think about how we can responsibly and boldly embrace it. It's not a kind of a future, distant future. It's here and now. And that's what we should stop thinking that it's not going to come here. It's already here and now. And from start thinking about it to building on Tim's point, when we don't think about just the pilot, you need to think about the platform. So start designing an enterprise-wide agent fabric, a shared orchestration layer that multiple teams can build on. Now, what does that layer mean? It means common guardrails, shared APIs and system access. We already talked about high quality data, but also unified monitoring and auditability, a reusable library of agent skills, cross-functional oversight and governance. I think you should start thinking of this as a platform and a shared orchestration layer.
Yeah, a lovely way of putting it. So let's think about those leaders who are maybe not at the point where they're thinking of AI as the now. What early signals should those leaders pay attention to when deciding whether an agentic AI use case is ready to move from concept to production? And Tim, as you mentioned earlier, too many POCs. Maybe we'll start with you there.
Did you say Tim? Sorry, you cut out for a second.
Yes, sorry, yeah.
Yeah. So yeah, I think that again, I go back to the people part, but you want to look for the signals that it is something that is going to solve a problem that people will be happy is being solved. Something that the other things I look at, and these are just to kind of, let's have a little fun, is like something that maybe feels a little magical, or maybe it completely changes the patient experience and to something really beautiful. So really making something that people can get excited about, and that the people who are involved in it don't feel threatened by it, but feel like, wow, this is going to do good things.
Ashma, how about you?
I would say Tim is absolutely right. The way to measure that, and we've seen that with our customers, where agentic AI has succeeded is the workflow is actually running smoother with the agents than without it. And if that happens, you're there. And that the early signal of that is we often talk about human in the loop, but we need to be careful that human in the loop should not be the cop out of making mistakes. So over time, you will see when it's ready to move, those interventions drop steadily and they cluster around explainable edge use cases. So for each escalation, if it's going to human, that means you're not designed it correctly. Humans need to be in the loop, and they need to be in the loop for the high quality. So you should see those interventions steadily go down, and humans are looped in for high impact, for edge use cases where they need to be in the loop for. But and also safety guardrails fire when they should and not when they should not. So early signal is we were working with a customer and they said, well, this was a nurse saying, I'm really checking it, but I'm rarely correcting it. So that shift is where they are looking into it, but they are kind of observing, and those errors go less and less. I think that's where, even for the safety guardrails, that it is actually escalating to human when it should. And that I believe that's a good signal that it is escalating at the right moment.
Yes, that's another excellent perspective. So in terms of practical steps, what practical steps could a team take this, maybe not this quarter, because we're pretty close to the end of it, but what could they take, say, next quarter to build confidence in the safety and reliability of agentic AI systems? Tim?
Well, I think there's a few things. I think Ashley might talk a lot about the guardrails and things of that nature that I think you need to do. I think starting off with cases that maybe are lower risk is helpful as well when you're thinking about safety and reliability, as well as when I think about that, also just helping people trust what you're doing so that they feel trust in what's happening. I have seen some places where they have built an AI that mimics a current system so they can kind of compare and kind of build that trust and see where they might go off the rails a little bit on reliability and safety and where they don't, so they can learn and feel comfortable in their next initiative.
Ashma, how about you?
I think very specifically to build on Tim's point is teams should implement their good practices. For example, in Google, we follow red teaming. We follow adversarial data set testing for the agents, and that goes into really intentionally feeding the agent ambiguous or adversarial inputs that forces it to make decisions about whether to use a tool, which tool to use, or which input violates a safety policy. And the more you do that red teaming, that adversarial data testing, the more you will get that. That's a comfort. Trust comes with verification. It comes with accountability. And so I believe in the enterprises, this red teaming and adversarial testing needs to be the first class citizen, and we need to build that muscle. It's a new level of engineering, and we need to make sure that it becomes part of the agent development lifecycle.
Excellent. Final one for our rapid fire round. What's the most common mistakes make when mistakes make? There's a classic mistake. What's the most common mistake organizations make when choosing their first agentic AI use case? What would be a better starting point, Ashma?
I believe starting with low impact, high frequency use case versus high stakes. Agentic AI, it's not ready for diagnostics type of use cases. So we often say start with back office use cases, or picking the right use case is critical. And that means where the stakes are lower, healthcare is an industry, it's a mission critical, I would say even it's life critical. So what are the use cases you will start in the back office to build the muscle to understand that engineering, and then go into difficult high stakes use cases? You cannot fast track this. You need to build that muscle. And I see that mistake being made sometimes. People jump to more cooler use case, high stakes. So there's a method to the madness.
Makes sense. And Tim, from your perspective?
Yeah, for mine, and maybe this is why some things get stuck in POC as well. But what I've noticed is that I don't know why, like humans, right? They want to do it and then kind of show everyone like that. Wow, look what I did. Um, but then the other people aren't kind of bought into it, and then it kind of fizzles. So, in large organizations, there's often siloed between technology and business. So I think technology using AI to solve business problems, but not including the business in it. And then it gets stalled. So I would say bringing both stakeholders, and there could be more than those two stakeholders, into the creation and ideation of it. And then I think you have a much better chance of taking it all the way through.
Perfect sense. And just before we move on from the rapid fire, we have a quick Q&A that I think we should clear up because we're going to talk about it a lot. Tim, could you define for one of our audience what POC is within agentic AI?
Sure. Proof of concept. So when you're just trying to prove something out that it works. I've also seen POT, proof of technology, proving the technology can do it. So
thanks so much. But very, very interesting rapid fire answers there. Thank you for your candor. Let's jump into the panel discussion. For the audience, we're going to go through 3 different questions, and Tim and Ashma will be walking us and talking us through some very interesting areas of agentic AI. So to start us all off, it's the sort of what are we seeing now question. Where are we? Where is agentic AI already reshaping patient access and care delivery in measurable ways? And what early outcomes prove it's more than just hype. Ashma, could you start us on that one?
Yeah, I would begin that question by sharing some of the stats, right? There's a projected shortage of around 10 million healthcare workers by 2030. This is a WHO stat. And we simply cannot afford to have clinicians spending today. They spend around 28 hours a week on administrative busy work. So where we're seeing traction is Agentic AI helping with that administrative friction. And that's where you will see the quantifiable result, and that also lends itself beautifully to the human in the loop, clinician in the loop, or nurse in the loop kind of use cases. So one example, we're very fortunate to work with major system like HCA Healthcare. They used AI-powered nurse handoff agent to summarize patient context across nurse shifts. This in any given day, they have around 60,000 handoffs on a daily basis. And so even if you add like 5 minutes savings are much larger, but if you're very conservative, now you're talking about 300,000 high quality nurse minutes daily going from documentation to care delivery. So that's where we are seeing the documentation burnout in the backdrop of having the shortage of nurses and clinicians. And to me, when you create capacity in the system, when the doctors and nurses are not doing the busy work, the documentation work, they have more time to have the preventative conversation with the patient. They have more. So we need to kind of create that capacity in the system. And we are seeing that. Another example is Meditech. They leverage Google's search and summarization, and it was 7.5 minutes per appointment because the physician is saving. When you are dealing with a chronic condition or a patient, their notes, they go multiple pages long. Expecting in that 10 to 15 minutes doctor's meeting to be able to get the summary of that, it's invaluable. So we are seeing AI as an assistive technology in those settings, be it in a hospital setting like HCA, or even these primary care kind of settings with Meditech.
And I can build off on that. Yeah, the ambient listening, like in the doctor's office, is like it's such a no-brainer, and it's such a game changer. I know a lot of physicians who have expressed how much they love that. And then again, also to Ashima's point, around nurses. So there's some studies done where like one less nurse, goes down, and the mortality rate will go up. So, it's not even just time, it's also life or death for patients because they get distracted, they can't give the attention that they need to give. So I think some of the stuff that Ashima talked about is really important. I saw another interesting one because a friend of mine joined this company called Diligent Robotics, where they have robots, so they can move around and they actually go and get things. So they're not even doing the administrative. They're like, can you go to the inventory and get this and bring it? And so it saves a lot of time. Or can you bring this here? Can you go get that? And they're actually already in production at hospitals. And I thought that was a really nice kind of innovation around AI and helping with the nurse shortage.
Yeah.
Oh, go ahead. You had something, Ashima?
No, I was going to just build on that point and finish your thought, and I'll jump in.
No, please.
I think from the care delivery perspective, there was another example that came to mind is, and this is, in the current science we have, the moral imperative is clear that when you think about cancer or early detection, we know that with the science we have today, the localized detection of breast cancer has a greater than 99% survival rate. Yet we know 20 to 30% of eligible women in the US are still not up to date on the mammograms. So what gets in the way? It's not the screening itself, it's the logistics. We all know the drill. We need to figure out, get a PCP approval, then we need to find out which imaging lab is offering that and booking all that appointment. So we will see Agentic AI come as that navigator, as your personal kind of concierge, helping you navigate the complexity of healthcare. And at HLTH, actually in October, we announced our partnership with Color, where we're seeing this vision kind of come to life, which is they're helping Gemini. It's a grounded on American Society of Cancer's data for cancer guidelines, assisting with the breast cancer questions or mammograms questions. Should I get it done? What does the nearest clinic mean? And then they actually go and book the appointment. So we will see from the patient-facing side, the care navigation um, is an area where we are seeing a lot of traction there in terms of agentic AI coming into the care delivery, but patient-facing.
And that's perfect for what I wanted to talk about, which as well, which is I was kind of calling it triage, but it's also very related to patient access. So I'm sure we've all experienced, like, there's been times I put off medical care because it's just too hard. Like, what kind of
Mhm.
doctor should I get? How do I get the doctor? Will they accepting patients? What, is their schedule going to work for me? Where are they located? Do they have parking? They're just like, it seems like a simple thing. You need medical attention, just go and get it. But it's not simple, and it reduces access. And then if you have, then there's a lot of people who have much harder accessing these things, especially in the rural settings and so forth. Um, so, I think that triage, and we actually did, I hate to say the word POC, but we did an initial one, and it's somewhat in production, but it's still a lot of it was POC, and it's actually with Google, and it was around that kind of triage, like if someone has a medical condition, helping them figure out what kind of doctor they might see, and then what doctors are receiving patients and so forth. And so it goes to some extent, but I can see in the future where, it would go to the extent of, basically scheduling you an appointment and making sure you can get there on time and so forth.
Yeah, and the color assistant that I mentioned is not a pilot. It's in meaning these technologies are coming in. It went live. It is helping women with scheduling and screening assistant. And we will see innovations like that, as Tim pointed out. Navigating health, navigating care is still very difficult. And that friction between a prevention and a patient is where agentic AI can be the bridge.
Certainly going to be a very exciting time for agentic AI. Thank you for your opinions on that one. I do wonder, there are probably quite a few people in our audience who are further behind than many of the amazing projects that you've just mentioned. Particularly love the breast cancer, and also the idea of just a robot designed to just collect things on your behalf. That's such a lovely use of it. But there'll be lots of people in the audience who are at a different stage in this journey. And it'd be really interesting to hear from both of your vast experiences in this, what the sort of highest value, lowest regret places for healthcare organizations to begin with are, and what foundations need to be in place in order to scale that safely. Tim, should we start with you for this one?
Sure. I think first of all, it's good just to think bigger picture when you're thinking about this, which is, what is AI good at, right? Um, and there's various use cases you can do here. And some of the low-hanging fruit actually has been just developing platforms faster, and moving. Lots of these organizations have very fragmented systems and data, and so modernizing those using AI to do that much quicker.
Mhm.
We actually did that for a claims mainframe that was supposed to take 10 years, 10 years, 10,000 screens to move over. But in the mainframe, it just was, you couldn't get access to the information, you couldn't easily make changes, so you weren't going to be able to adapt to future needs. And we were able to, using AI, to reduce it to less than 3 years, so 3 times acceleration. So I just want to put that out there because that's very low-hanging fruit that any organization can start to do, that I think is really useful. But again, going back to some of the other things like high volume, high variability, where there's a lot of data, I think can be used. One of the things physicians have to do is they have to keep up with research. So
Mhm.
applications where it helps you kind of summarize and keep up with that research is a really great place to start. Um, a few other places we talked about the triage. I think that's a place we're seeing a lot of. Um,
Mhm.
I think I think patient experience is a huge place, where you can really understand a patient much better and really kind of cater and navigate, as Ashima was talking about. Um, I talk about a couple of examples that we've done. There was one that was interesting, and this is in the health insurance space, but every year for annual enrollment, people have to, they enroll for Medicare Advantage. And to check eligibility, there's actually a lot of questions that have to be answered. And so these organizations have to hire, hundreds of people just temporarily to kind of overlook and see who's eligible and who's not. And there's like, so it's rules. So there's something else AI can do well. You can feed AI these rules and say, follow these
Mhm.
rules. And so, we were able to build something rather quickly. Probably in the old world, that would have taken a couple months. It took a couple days for an agentic system to basically take in and do hundreds or thousands of applications and check if they're eligible or not. So that's just that's like a quick hit, like very easy to do,
Mhm.
makes the process much faster as well. So better experience for the people who are trying to enroll.
Amazing.
Cool.
How about you?
Yeah, I would add to that. So I'll give you an example. We worked with American Society of Clinical Oncology, ASCO, and when we were talking to Dr. Huddis and the team, they mentioned that they have around 50,000 plus ASCO members slash oncologists in their community. And these oncology guidelines can continue to evolve, new research comes in, and then they continue to change. Now, for oncology, and for these thousands, tens of thousands of oncologies, the latest oncology guidelines are not easily available, right? They are buried in PDF, but PDF is like around 70 to 80 pages long. So what we did with them was, and this is a common use case by the way, most health systems or payers, they have policies, they have guidelines, they have clinical protocols. So our first step was ingesting all those guidelines, vectorizing them, and grounding Gemini on those so that an oncologist, whether you're in Nebraska or California, or Florida, you can get access to the same guideline through conversation. And to me, that was one thing that we launched. I believe this was this year in March, and this has been such profound change for them in how they access the latest uh, clinical guidelines. So if I'm a melanoma, I'm treating melanoma, I can ask what is the first line of therapy for this, or what are the latest clinical trials, things of that nature, which are very, very hard for oncologists to figure out and search and spend time on. This is where AI is acting like an oncology assistant, giving them those tools. And that pattern, by the way, is repeated. Like let's take the medical necessity guidelines for revenue cycle management. We're working with IKS Health, and they're doing very similar thing. Tim gave the example of Medicare Advantage, but most of the payers have a medical necessity guidelines for prior authorization. And if I'm a hospital system, I need to understand for what procedure, for what diagnosis, what are the medical guidelines for us to get paid for that claim. And it's the same pattern. Get the guidelines, which are buried either in documents, PDF, thousands of pages long. This is what AI is actually good at. It can ingest all those thousands of pages, and we call it vector representation on those embeddings, and now you can converse with it in a language which is much easier. And this is to me democratizing access to expertise looks like. In the case of ASCO, we're very proud, and this is, by the way, a global solution, not just US. So you're in India or in US, you have access, easy access to the same guideline. To me, that is what democratization of health looks like. We all need to elevate our expertise and make it easy for people to take care of the patients.
Yeah, absolutely. I mean, it's a huge imperative on everyone involved in healthcare to do so. Tim, did you have any final thoughts on that one, or?
Yeah, I would say because we're talking about where to get started and how to think about it. I think a lot of people, the elephant in the room, like hallucinations, right, when it gets it wrong. Um, I was in a class one time with this psychologist. He said they shouldn't be calling it hallucinations. It's not really hallucinating. But that's how it's become, right? The term is hallucination. And so, um, it's interesting because yeah, there are hallucinations. And I was reading a paper recently um, about like how you design the system, you can really minimize those hallucinations. And this paper was doing the towers of Hanoi, which is like a reasoning problem. If you know it, like there's like three pegs, and you have discs of different size on one, and you got to get it to another one. And when they just asked the agents to do its thing, then it would it would hallucinate within like 100 moves. But then when they divided every task into a very subtask, and then whenever these tasks would happen or these moves would happen, then they had voting agents. So then the voting agents would vote like, is this the right move or the wrong move? So this is what I was talking about, the infrastructure you want to put in. When they did that, they were able to do over 1 million moves with no hallucinations. So how you design it and how you break it up is really important to making sure that you get a result that you can trust. So I think that's one thing that's important, and then also just call out bias. Um,
Mhm.
Since yeah, I was in a shout out to Dr. Shannon Blackman. I was with her the other day, and she has a whole presentation on this. But she was referring to, I'm sure most of you are aware, but you know, Amazon had used AI around hiring, and it was trained on the previous data of all their hiring, and so it was very biased towards men. So you know, if it was a women's college, then you would get demoted. And so, you know, really checking because you can hurt other, you know, groups of people, you know, and we all know like skin, when you talk about skin systems, you know, they perform worse on darker skin. So really thinking about that, and that's why we talked in the rapid session about how important it is to think about the ethical, the bias, the standards around how you do these things. So you want to bring that into whatever you're doing as well.
Ashma, how about you? Any final thoughts?
Yeah, I would say the technology is getting better every day, right? But healthcare will move at the speed of trust. And trust is very hard to gain and very easy to kind of break, right? The every technology is improving every minute, and trust takes years to build. So that's why this guardrail, this evaluation, how do you actually check for hallucination? And to me, that guardrails, that testing frameworks become the muscle, right? I often say this is a new level of engineering. It is better to get it right than to get it fast, if that makes sense. You can't sidestep those steps. You need to ensure. And now we have, so from Gemini perspective, from Google perspective, we are building those evaluation framework that you can actually have humans check the output. And with each cycle, that gets better and better. And now with the large model like Gemini, we have a 1 million token window. What that means is you can actually pass the entire context in the prompt. You can have the entire guideline just like in context learning, so models responding from that context. So to me, technology will continue to evolve. It will continue to get better, but healthcare will move at the speed of trust. So be very thoughtful on how you're implementing these first use cases. Have the right guardrails, right governance, understand the workflow, the process map. As I always say, it's 20% model, but 80% of that is the operationalization of this people process.
Ashima, I love
Very.
that healthcare moves at the speed of trust. That's great. Great quote.
I would imagine that may weevil its way into the Health Europe agenda at some point when it gets finalized. It's a really lovely way of phrasing it. Let's move on to our final question for the panel. What new partnership models will allow life sciences, payers, providers to safely share data, co-develop and scale agentic AI solutions that will work across healthcare? Tim, I think we'll start with you for this one. What are your thoughts?
Yeah, I was thinking about this. It's very interesting. There's obviously there's a lot of partnering going on, and we partner with Google all the time, which is fantastic. Um, I think also I haven't seen as much of this, but you know, just putting ideas out there into the ether. Um, you know, I think there's data. Data is like the lifeblood of what AI can do, right? So if you think about patients and you think about if providers have all the data of what happens, you know, when they're kind of in the hospital and payers have the data when they're outside, right? Their claims and so forth. I think the combination, those type of partnerships, you could get a much deeper view of a person. And through that, you could learn things, you could help support them better and help them navigate. So I think that's one really interesting idea. And then I had one other idea, which was I was so these are just ideas, but I just put this up there too because I was reading. Oh, you can't see it. Okay, it doesn't work. Anyway, it's called Patient Priority. I was reading this maybe a year ago, but I was thinking about it in the context of AI, and it was talking about this clinic in Germany. I think it's called Martini Clinic, that is specialized in treatment of prostate cancer. And so what they did is they went huge specialization, completely built around the patient, right? So not built around like functions within the hospital. And then very disciplined about the data and always tying everything to an outcome. And they track the outcomes, not from when they left the hospital, but for 10 years, right? So very longitudinal data. So very crisp, and AI would have a field day with all that data, all that clean data, which you need. And we don't have enough of those examples. And I think you could do that. You could have specialization, or you could have those type of disease areas where providers share across barriers and have a repository or registry where the AI can also play into that. And you could really reduce the cost of that care and the efficacy of it. So I think that's my bold idea to put out there.
And Ashma, how about you, from your perspective? What new partnership models are we likely to see?
If you take a step back, here's a key friction point in healthcare. And I was reading that, I believe there was some report that less than 3% of healthcare data is effectively used today due to the system fragmentation and silos. So when you think about payer, provider, pharma, we are creating silos and this data is not shareable. And to me, this will be the biggest impediment for agentic AI. I also say API before AI. And what that means is we need to be able to have standard-based access to data. And in wearing my policy wonk hat, like fire APIs to be able to exchange information is going to be key. And to me, this is why the Amy Gleason's work in the CMS for CMS interoperability pledge, which Google has pledged, is to be able to share patient data, or in case in the tool that you're building, making sure there's an API. We are building tools for payer and providers to be able to leverage standard-based data exchange. And to me, those are the type of partnerships we need to see where there's a value creation at both sides. And healthcare has not traditionally been like that. If you ask them who owns the data, is it the hospital? Is it the EHR vendor? Is it the patient? I think that needs to turn on its head, that it needs to be consumer mediated data exchange where a patient should have right to their own data. They can share that with their own payer, provider, life sciences, research company with their consent. I think that hasn't happened yet. And we cannot afford that. Like we have been talking about data interoperability for, God, like 10 years, or maybe longer. We cannot afford now, as we go into the AI interoperability. There's an agent, but it cannot access the patient data. It cannot have the access to the claims data. For agent and agentic AI to be that assistive technology for clinicians, for patients, that data liquidity is going to be the bedrock. And I believe that's closed model in any new partnership needs to be open. So from cloud perspective, I can tell you, we support Gemini, but we support 100 other models. Similarly, I think that mindset about ecosystem, about platform thinking needs to come to healthcare, that it's no lock-in. Like lock-in will prevent progress. And as we head into AI, it will be even more pronounced.
Yeah, so true. It's she hit it on the nail right there, because it is a problem even in organizations. One organization, the data is not you can't get at it. And we're doing a lot of foundational work in that right now, which is a proof point for that. I think also it's important to point out that you don't have to expose all your data, right? Like you can expose it in different ways. You can expose the conclusions of it. You can have things that take the data and put it and just map the relationships, and that's shared. So it doesn't have to be giving away all the data. So there's a lot of different kind of configurations that can make it palatable for people. But yeah, we need that interoperability that Ashim was talking
And
about.
CMS has done a good job, Tim. They have now recently, Amy Gleason have done interoperability pledge. That is the basic set of data that should be able to exchange about the patient and giving that consent to the consumer to be able to share that data. To me, going back to the point, no AI without API, meaning an easy way, a standardized way to access the data so that an agent can do the good things. It can help me book my appointment. It can help me with the medical literacy or help me manage my care management plan. But if we can't access the data, we'll create these kind of dumb agents which don't have the data to have the agency to be able to perform a task. The big shift from AI to agentic AI is information to action. These agents will have action to do, book my appointment, help me understand my care plan. And that action cannot be completed without it. So just to, again, I think as an industry, all of us have this kind of moral obligation that we need to do right by the patients, have the consumer mediated kind of data exchange. Growing up in India, I had a doctor nearby would always give me the note. It's a family doctor that knew all about me. And now I compare and contrast. When you go to a doctor, they're like, I see their back because they're busy entering, and I don't know what's been entered. I think that bridge where technology is actually invisible, and I believe agentic AI will get us there. That invisible, it feels kind of magic, but you have that information and the physician knows about you, and that humanity and judgment will be firmed up if that documentation and the other burden kind of goes away. So to me, that's the future we should all aspire to.
It's a really beautiful way of putting it. And Tim, any final thoughts on this one before we move on to our Q&A?
No, I think we covered this one. It's perfect.
Good. Some really, really interesting bits there and some lovely terms of phrase, as well as some interesting stats. It's amazing that we are using less than 3% of that health data. That's both terrifying, but also quite exciting for the future. So we've had quite a few questions, thanks to our audience. So I'm going to start you off with one that I think is quite front and center for a lot of people at the moment. So cybersecurity is of huge importance with progressive and more complex risk. AI obviously creates some risk, and there are the risks of hacking, threat actors. How are your organizations, how have you seen other organizations build confidence for clinicians, patients, and administrators that agents will be secure? Tim, can we start with you for that one, please?
Yeah, I think I'd probably start with that. Like when we work with our clients, and it's always we call it zero trust.
Mm-hmm.
So you don't want data flying all around the place, right? Like you don't want data that you don't need to see. You want it to say where it is, where it's secure. And so that is kind of the foundation. It's sometimes it feels a little bit more painful to do it that way, but that is really important. Because at the end of the day, that's the data does need to be protected. And so that's probably one of the key things that we focus on when we think about kind of security and keeping your data safe.
I would add to that like 2 points. One is, as Tim said, because these agents will act, they need to have that orchestration layer that's managing kind of see your central nervous system. Which agent has what access? How am I securing that? I think that orchestration layer, I call it the LLM ops, or you can call it the agent ops. We offer that as part of Gemini Enterprise. That is going to be key because as you're building agents, this will get complex, and getting that permission aware responses, permission aware agent execution is where that orchestration layer plays a critical part. The second is the whole concept of red teaming. trying to break the system. We had when we launched, we have a kind of break team, and they test with the adversarial data sets, red teaming. That will give the confidence. So, and we offer that in security ops as well from Google security perspective. The agents will increase the attack surface area, right? Because now healthcare especially was built for patients coming into the facility. Now we're asking the mobile apps, the agents to have access to that information. And to me, those are you need to secure the perimeter, zero trust, and have a complete, like we support HIPAA compliance, security, SecOps. And now these attacks will also get sophisticated. These attackers are also going to use agentic AI. So you need an AI-enabled security operations, and they all gonna go hand in hand. What data and systems the agents have access to, making sure they're permission aware. Second, building the platform with the right guardrails with security operations to see this attack vector and guarding that. And third is designing the workflow like that. So all this kind of comes together.
Makes perfect sense. So there's a really nice high-level question here that someone's put through, which may sometimes get lost in the weeds a little bit. But how can an organization tell when a problem is a good fit for agentic AI? What's a good sort of methodology for looking at a problem and going, we can solve that with agentic AI? Ashma, can we start with you for that one, please?
So I think that's a great question, by the way. Not every problem is an AI problem. Not every AI problem is an agentic AI problem. So I would say if there's any workflow that is multi-step, which is high frequency, I think that's where I would start. So understanding your workflow, your process map is important. Oftentimes we see that workflow, which is high frequency, you're doing it a lot, many times, and it's very contained. I would say start with that and then go the more complex, the more nuanced. I think that's where you need human in the loop design. But I can tell you, not many organizations have well understood workflow process or process map. So starting with that, understand the process end to end and then figure out what is a task which is isolated enough, high frequency that I can put an agent to that. And then, of course, then there's multi-agent. Tim talked about that. We are seeing this multi-agents where one agent does the work, the other agent verifies. So there's a whole methodology like that. But first, if you can't even get one agent to work independently before going into multi-agent, I think you'll introduce a lot of complexity. So starting small, high-frequency problem. Like the example I gave was like nurse handoff. They didn't start with all of the documentation in a given hospital setting. They went very specific onto one use case. It was high frequency, 60,000 handoffs happen on a daily basis. And that's what they said, we'll solve it. And you will see those high frequency tasks, which are like, it takes a nurse 60 to 75 minutes per handoff, and you save 5 minutes. That's value add, that's ROI. So finding those right problems, high frequency, where there's a lot of toil, administrative burden can be your guide.
Excellent.
Yeah, and taking that example, it kind of goes like what I was talking about is like doing AI that feels magical or brings joy to people who it's going to interact with. So if a nurse has that extra 5 minutes, that is something they're going to appreciate. So I think that to me that those are a lot better places where humans can be like, oh wow, this makes my life better. The second thing I think you can look for is solve problems that can't be solved without AI. And this isn't a specific problem, but I was in a panel a few weeks ago about rural healthcare, and there's a dearth of finances for it that there is going to hit some type of cliff coming up. And the consensus was that this, outside of changing policy, this cannot be fixed without AI. So let's get creative. Let's think about how that could happen. So I think, I think you said this, Henry, at the beginning, like the art of the possible, thinking what can you do that will really change the game, that can solve a problem that couldn't be solved before. I think that also makes it really exciting.
certainly. And I think, well, not for me to think at this point. Let's move on to another question. So there's been a really interesting one, I think, that comes up not as often as it maybe should. We talk about security a lot, and we talk about some of the zero trust pieces that you talked about earlier. But let's have a think about the regulatory challenges. What are the regulatory challenges? And I appreciate they will change from market to market, nation to nation. But what are the regulatory challenges in the future for the development of agentic AI in healthcare?
I would say from Google's standpoint, we believe AI is too important to not regulate and too important to not regulate well. So this is going to be critical from AI kind of regulation perspective. And I would say that it's a different beast we're talking about, right? When there's a general purpose technology, you've taken an example. When you, let's say if it's not general purpose AI or LLM, you're defining a medical device. It served a purpose. You tested it for that. The regulatory framework for software as a medical device kind of exists. Now, this model is general purpose. It can solve many things. So how do you put the guardrails around it? How would you test it? And to me, that's where the opportunity is to start with even what are the AI principles? What things this agent will do, not do? And second is um, what should be the regulatory framework? And I believe FDA and the organizations are working through that, but it's too important to not regulate. And
So I agree with that, but taking a different angle on regulations. So healthcare is highly regulated, and AI can actually help. So lots of times the regulations have slowed things down. We were this was in pharmaceuticals, but when they create content, it has to be what they call MLR review, so medical, legal, regulatory review. And so it can take a lot of time, a lot of extra costs, a lot of time to publish content. And you can use AI actually to help understand the rules. So it will help you kind of create the guardrails and create content that can be much easier, more easily approved. Therefore, making things a little bit easier, more cost effective and better. So I think there's areas we have to regulate AI, but AI can help with the healthcare regulations as speeding things up. And so, it's really good at looking at rules and following them. So
yeah, AI can be an assistant for regulatory reporting, filing the MLR. I think the question is, how should we even regulate such an important technology? What principles do we need to place? Do we need to have state by state? Does it need to be at the federal level? I think those are open questions and open dialogue today. We believe the variability, if every state is designing their own, then versus a federal one where there's a rule that comes and which has kind of common guardrails. And you don't want variability because when you are a tech partner or Tim, you're working in the services, understanding the nuances, if everyone is implementing regulation differently, it becomes very, very complex. It will become a fragmented mosaic of solutions, which are very hard then to build solutions for. So we definitely hope that there's a federated regulatory framework that we all can adhere to versus 50 different set of rules, then that's become very hard to manage complexity for.
yeah, I would love that. That'd be great.
Thanks. So we've got time for, I think, two more relatively rapid ones, but I think this one is very pertinent to the people I see in the audience today. So what are some examples of real use cases for healthcare that can be done by smaller entrepreneurs, not just large enterprises like Publicis or Google? What are the use cases you've seen for those smaller healthcare, health tech entrepreneurs in agentic AI? Tim, could you start us off on that one?
It's interesting. I mean, I think a lot of the examples I gave actually can be done. Like the teams that we had do them weren't that large. So I think it's really finding where you see value can be had and then building it. So I'm just looking, I know I gave a couple examples, like we talked about the Medicare eligibility. Anyone could do that. That wasn't special to us. Some other examples that we've done that anyone could do is we did one around competitive intelligence, which was basically helping understand if you have a brand in the market, whether you're a provider, a payer, pharma, whatever you are, how are people receiving it, right? You can have AI kind of scanning the social boards and all that stuff. And how are people receiving your message? Is it resonating? Are there gaps in what people think? Maybe there's gaps in their understanding of what you're providing. So you could create something like that. And any entrepreneur could create that. Like that's kind of the fun of AI, is that most of these things can be done, whether you're very large or small. I mean, the only thing I would say is that you need you need data. So competitive intelligence is a nice one because the data is all out there in the public domain. If you're working for a provider, then you can figure out possible ways to look at their data. There's a lot of cases around doing more predictive intervention type work by looking at that data. So I think those are some
Yeah.
examples people could try.
I think as Tim was saying, as foundation models, frontier models are becoming more affordable, more accessible, I believe this is democratizing access to building that expert solution. So whether you're a small company or a big company, these frontier models are making or democratizing that development. And one of the things that we've seen small companies do really well is search and summarization. It's a very small use case to be able to search on a medical record or summarize it. Now it has many, many use cases. It could be done in the primary care setting. It could serve the nurse handoff. It could be your prior authorization medical necessity check. So building the building block of search and summarization, grounding it to that context. If you solve for that building block, you solve for many, many use cases. So I would say when you are thinking about building solutions, so think in terms of platform thinking, not narrow POCs, because these building blocks will then serve many, many use cases. So I would say get expertise in those areas.
Perfect sense. Look, we have just over 2 minutes left. So with about 45 seconds each, if our audience were to take away one thing from the last hour, which has been exceptional from both of you, what would you want them to take away about the future of agentic AI and what excites you both and what that future looks like? Tim, could we start with you?
Sure. Yep. So I think a couple of things is that I would emphasize is that this is to serve people. So make sure that the people in your organization that you include them in it. So it's part of our solution and not just your solution. I think that's really important. I think have fun. Like it's really cool. It's really magical what it can do. And then another bold idea, because I was at the doctor's recently and for a surgery, and they're like, well, we don't know the price of the anesthesiologist, we don't know the price of the facility fee, like it's just so, and then like maybe if you call this number, maybe you'll get it. So I'm just hopeful that somehow this can pull together a much more cohesive patient experience that doesn't just make it such a burden on the patient. So I would love to see. I'm excited about it.
Ashima, from you as our final thought for the day.
I would say this is one of generational opportunity for us to reshape healthcare and make it more affordable, more accessible for everyone. And now all of us have this very powerful tool, and it will come down to healthcare community and what use cases we will solve. But in the past 10, 15 years that I've been in healthcare, this is one of the most exciting times to be in tech, and also one of the most fulfilling and meaningful time to be in the intersection of health and tech. So I would say keep your motivation, keep that energy and inspiration. We have work to do.
Energy and positivity. I can't think of a better way to sign off. Thank you both so much for your time and to our excellent audience. I'm sorry we didn't get around to every question. There are, in fact, 12 unanswered questions, which I think might be a record. So a sign of how engaging that was. Thank you both, and we will speak to you all soon.
Thank you to Publicis Sapient, Google Cloud, and everyone that joined us today. Please visit our website, HLTH.com, to catch up on all health webinars and watch the recording of today's session. Join us in Los Angeles, February 22nd to 25th for Vive.